not even half of people will go into remission. They'll still continue to drink. Sure. So, quick review, Dr. Rodriguez gave me the little handout that he gave to you, which is really helpful, which is why I created a little handout for you so you can complete it. But just kind of a quick review, get awake. What is considered a standard drink, and what does it mean to be a risky user, and then binge drinking? And it has to be you guys, because I think these guys are muted. Yeah.
1 beer, 4 ounces of wine, and what, a shot of whiskey?
What's it mean to be a risky user?
Oh, whiskey user?
Risky. All right.
Oh.
That's why I'm not wearing the mask.
Somebody that drinks and drives?
Drinks and drives, yeah. What else?
Promiscuous sexual behavior?
What about the number of drinks?
Binge drinkers?
2 or more.
Because remember, there are people who are risky users, so that means they drink a lot, but they don't quite fit the criteria for alcohol use disorder. So that means that they don't quite have that DSM-5 criteria, but maybe in the future that might happen. So you guys were on the money for this one. I found this picture online, which I thought was helpful. So it can be a 12 ounce of beer, malt liquor, 5 ounces of wine, or a shot glass considered one drink. So the person who, for our case, 8 to 10 beers a day. So that's probably about 8 to 10 drinks per day. And then risky use, depending on your age and what gender you are, depends on like what drink. So for most men, it's 4 more drinks per day, or about 14 drinks per week. And then for women and older men, it's 3 drinks per day. And we'll kind of talk about specifically with women why that number is so different and why that risk is more. And then there's binge drinking, so that's all in one setting. I have at the end of this PowerPoint, which we can send out to you too, just an appendix of what happens at this blood alcohol concentration, what happens at this, but that was not really part of ours, because we're kind of dealing with more of the withdrawals and the detoxification. But I have that there for your reference. So as a pharmacist, I'm going to talk about alcohol as if it's a drug, because I do consider it to be a drug. It has a lot of effects on the body. It can be very dangerous. So specifically talking about alcohol metabolism and why people and their bodies get hurt the longer that they drink. So the process starts with ADH. That's an enzyme that breaks down actual ethanol, which is the alcohol you consume, to this metabolite called acetylcholine. And this is the metabolite that's very toxic if you have it chronically in your body. So the longer that you have that, the more damage that occurs in some of the areas like the brain, the gut, the heart, just from that exposure to that. And the reason why that is because alcohol follows a zero-order kinetic, which means that this pathway number 1 at the top, can only work so hard before it gets tired. And when it gets tired, it stops working. So that means instead of going all the way through and changing alcohol to acetate and water, it remains this acetaldehyde, which means it chronically is in your body, and that's a very toxic metabolite to have chronically. And also when you get saturated, which means it gets tired, you have this buildup, you have the secondary pathway that's like, well, we have to get this out. This can't stay in our body. This is hurting us. What can we do? And so the secondary pathway tries to get it through so that it can. But the problem with that is those metabolites that come from that secondary pathway are also toxic. So when you drink a lot of alcohol, and you, especially those binge drinkers or those heavy drinkers, and it tries to go through this pathway, you're just going to have this buildup and things are going to get damaged. So that's kind of the overall process. Does that make sense?
Mm-hmm. Good.
So this is what I was talking about, the battle of the sexes, men versus women. You'll notice throughout the series, I'm going to probably continue to compare men versus women, because I think women kind of get screwed over a lot in a lot of things. But it is more detrimental to one's health. Why do you think that is? Thinking about what I just told you about the metabolism, why do you think that is?
We have more fat cells.
Yes, we have have more fatty tissues. What else do we have?
Estrogen,
Lower metabolism.
yeah.
So what happens is not only do we have less body water, so we're more fatty than we are water. Water dilutes alcohol, right? So if we have less body water, we can't dilute the alcohol the way we should. That's risk number one. Then we also have more fatty tissue. So normally what happens is as it stays in the blood is considered water, it gets diluted. But we have more fatty tissues. So that buildup in the blood just becomes too much. Because men can distribute that throughout the body, so it's not all in one spot, and then they can excrete it, and they'll be great. But women, it gets stuck for longer periods. And that enzyme, that ADH, that's responsible for getting rid of that really toxic metabolite, we don't have as much of. So we have three ways that alcohol use for us is going to be more detrimental. So sometimes you'll see people, women come in, and you're like, why is this worse than this man I just had? This could be one of the reasons. Is that like something common that you see, that women tend to have it worse?
I think it's something we don't pay attention to.
It's true. It is very true. So from your experience, what all have you seen alcohol do to the body? There's hints up there if you need hints, but what are some of the things that you think of that these are medical conditions that people that drink alcohol chronically have?
Fatty liver,
Fatty liver?
esophageal varices from the portal hypertension.
So she said esophageal varices. So I just wanted to point this out, that as great as it might be in that moment, kind of explaining to them, this is long-term. This is the reason why you're getting hurt, because those metabolites are attacking everywhere. Because most people just think the liver, right? The liver is what's going to be affected. But really, it affects everything. And that's something, as you're talking with these patients and educating them, just to kind of keep in mind for them. But for me, and this is where the drugs come in, it goes down to a neurotransmitter level. So not only does it affect your organs, but it's affecting your little bitty molecules too that do a lot of the work. And these are going to be the main ones. Your endogenous opioids, so those are what's released in your body when you do something that you like, you eat a food that you like, and you have this pleasurable feeling. That's what's causing that, endogenous opioids. So when you drink alcohol, those are released throughout your entire body. So you feel good. You want to drink again because it feels good at the time that you're drinking, maybe not later, but it does feel good. And this is also what reinforces consumption. So you get through this process, it feels good, I know it feels good, so I'm going to do it again. And it's just this reoccurring theme. And this is particularly important. The opioid part is not a huge component of it, like GABA and glutamate will be, what we'll talk about. But it is one of the drugs that we use in order to help people abstain, which we'll talk about a little bit later. But I think the main drivers here are GABA and glutamate. So what do you know about GABA versus glutamate? You just trying to get an idea of what you've been told in the past. Okay, if you don't. So GABA, consider GABA the brakes of your body. It's an inhibitory neurotransmitter. So if GABA is released, something's being stopped. Versus glutamate's the opposite. So it's the excitatory, it turns things on. So the more glutamate you have, the more active someone will be. So what happens over time, maybe right in the beginning, like with GABA, you're turning things off, it makes you tired, you don't have as much anxiety at the time, you can have some motor function impairment. But over time, the longer that you drink alcohol, your body will adjust, and all of a sudden you're going to have way less GABA. That's why people are like, I used to drink a little bit, and now I have to drink more to get the same effect. This is why. It's because over time, your body's like, we're using this way too much. It's tiring me out. What can I do? Let's get rid of those receptors. So that means we're getting rid of our brakes. So what do you think happens to glutamate? It goes up. So it does the opposite. So when you first start drinking, it's great because it can help you kind of forget all about all the bad things, that like fuzzy feeling that you get. But over time, again, it really cranks up. So now you have a car that's driving really fast without any brakes. And that's the problem. And that's where majority of our medicines for actual withdrawal work, is that system right there. Other things are like dopamine can be increased, which again is what makes you feel good. Same with norepinephrine. So all of those are increased at the time, but those play a little bit less of a role than the GABA and the glutamate do at this time for treatment purposes. Any questions about that? And here's just like a good schematic that kind of says exactly what I'm telling you. So when you're intoxicated, your GABA goes up, your epinephrine goes up, your dopamine goes up, your serotonin goes up, so all of these things go up.
Then our patients' clothes come off.
Yep, yep, exactly. But when you're withdrawing, it's the opposite. So all those good things go away. So this is exactly what I was saying, is that you're using this car without any brakes. And so when you're super excited, so kind of describe to me when you think of someone that's really excited, what's their signs, like what are their vital signs like, what are they like, versus if they're not.
Blood pressure's gonna be higher, heart rate's gonna be higher.
Mm-hmm. And those are the symptoms on the CIWA score, right, that we're monitoring for to see do we need to treat them or not. So our car is going, our brakes are off, and that's why you get that agitation and why you get those symptoms. Does that make sense? I had to go a little bit more in detail with that because that's where our drugs work, and it makes it make a lot more sense when you realize exactly mechanism-wise why this is occurring. I'm not going to spend too much time on the signs and symptoms. I'm sure you guys are experts at it. I know Dr. Rodriguez talked about it, but I had to put this in here. So do you know why I have those pictures there? If you remember, the top one is from that horrifying, scary scene from like Dumbo, where they're like super intoxicated, and I had like nightmares about as a kid. Yeah. So why would I put that? And then the second picture are a bunch of little people from it's a book from I think the 1700s, not even the 1900s, the 1700s. Yeah. So something that I learned recently that's very interesting is the most common hallucinations that occur are those two. I don't know why, don't ask me. I try to look it up. I can't figure out the reason, but those are going to be the most common hallucinations. And actually, there used to be an alcohol that was sold on the market called DT, delirium tremens, and it had a pink elephant on the bottom. Interesting enough. But the autonomic hyperactivity is really the focus on why they're here. I mean, if they're having seizures, if they're having DTs or hallucinations, that makes their withdrawal a little bit more severe. So for a lot of the times, you probably see more of the autonomic hyperactivity, which is the symptoms that you guys were telling me. Hallucinations, more rare, usually visual, but they can be auditory as well as tactile. So it just can kind of differ depending on the patient. Withdrawal seizures are even more rare. They're usually tonic-clonic. And then you've got DTs, which is the most rare, but very, very deadly if it happens and it's untreated. And then I think Dr. Rodriguez talked a little bit about the timeline. So depending on where you're at, the autonomic system differences, because your GABA and glutamate are usually the quickest neurotransmitters in your body to work. So that's why you get those symptoms first. And then over time, your dopamine starts to have a reaction, and then you get some hallucinations, and then eventually maybe go into DTs. Now, depending, I mean, if you have a blood alcohol concentration of 400, you're probably pretty likely to have a seizure earlier on. It can happen at any time, but usually for the most part, from what I've seen so far, we don't have as severe withdrawal as it could be. But that timeline can last anywhere from a few hours to days. So let's talk about treatment of alcohol withdrawal. So going back to our patient, is he going through withdrawal? He has tremors, headache, nausea. He's probably going to. So how do we treat him? How do we treat him here? What do we do? You have to talk louder. What drug do we get?
Ativan.
Yep, we give Ativan. So overall, our goal is to prevent those symptoms from occurring. We're trying to beat them so that they can be comfortable, and then making sure they're not going into seizures and they're not going into DTs. And then overall, long-term access, because we're only a stepping stone. they're probably not the most important stepping stone, because for them is, you're going through this now, but this is for a short period, we really need to make sure this never happens again, because the more withdrawal you go through, the more risk you are for seizures, hallucinations, CTs, and then once you have those, you're even more at risk. So it just kind of builds on itself. So what do the guidelines recommend? So why are we using Ativan? So as you can see, it's pretty unanimous that benzodiazepines are the drug of choice for alcohol withdrawal. And we'll talk about why that is in a second. So even the most up-to-date 2020 guidelines from ASAM recommend benzos first. So that's why on our protocol, we've chosen Ativan as our first line for these patients. So you may hear more, carbamazepine used to be used a little more often. It used to be more widely available as an IV medication, not so much anymore. There's some minimal data on like divalproex, so valproic acid. But really, benzos, gabapentin, and now phenobarbital have been the most talked about drugs for treating alcohol withdrawal. So here is part of our protocol. I've linked certain medications throughout this presentation. But again, like you said, Ativan is our drug of choice. So why? What do you think, going back to those neurotransmitters, what do you think a benzodiazepine does in order to stop withdrawal symptoms? So remember, our car is going, but our brakes don't work. So what part of that car do you think? Yes, benzodiazepines fix the brakes. So it doesn't fix the problem, it just makes it more imbalanced. So that's why we use benzodiazepines, because they're the best at doing this. And that's why we've chosen things like gabapentin or valproic acid or phenobarb, because they do something very similar, but so far what we've seen, benzodiazepines do the best job. So just like I said, we're focusing on the brakes. Let's increase the brakes, let's fix those, and then those symptoms go away. So which regimen should we do? There was recently a protocol that was released on should we be using CIWA, should we be doing a Librium taper, and why we use each. And so this kind of explains the difference and why we chose that algorithm the way that we did. So they've done a lot of studies to see, okay, should we be doing symptom triggered, which means you do a CIWA score, and you're like, okay, it's this amount, I need to give this amount of drugs. Or should we just be giving them a fixed amount of benzos every day so that we don't even have to wait for the symptoms, they're just gonna go away. So symptom triggered is the standard of care nowadays, mostly because it minimizes how much benzos that we're using on a day-to-day basis. Because what's the point of giving a benzodiazepine if they're not having any symptoms? All you're doing is putting them at risk for side effects and not really helping them in any way. It could prevent rebound symptoms from occurring. But again, we want to minimize how much benzos that we're giving on a day-to-day basis. The problem with using symptom triggers is you do have to be pretty well trained in using the CIWA. As I'm sure that you guys have noticed, it's very subjective. So you may give someone a 12, and then you may give someone a 15. So you really have to be pretty well trained on how to use it to make sure that we're using it appropriately, which makes it a little bit harder. Versus when you have a fixed regimen, you just give them something. Here's some examples on here. We usually use Librium in most places, not just here. We use Librium, and we'll talk about that a little bit. But just because Librium, it has a shorter half-life, so it doesn't stay around as long, and it can be dosed once daily if you need it. But usually what happens is you start at a higher dose, and then you titrate down as the symptoms go. Which again, could mean that they're in the hospital for a longer period, 5 to 7 days, because you have to wait for that taper to go away. You have to make sure that once their taper is gone, that their symptoms are actually gone. Versus symptom triggered, you're just waiting for, okay, they haven't had any symptoms for 24 hours, I think they're good to go. So these are some of the more commonly used, depending on where you look in the literature, benzodiazepines that are used. They've done studies comparing them, and there's not one that is better than the other. So if you use Librium versus if you use Ativan or you use midazolam, whichever one you use, it's going to be the same efficacy. It doesn't really matter. Librium was the very first one studied, so a lot of people and a lot of institutions may be able to use that one just because they're comfortable with it. But they're all equal in the eyes of literature. So the two that I'm going to focus on our Ativan and Librium, which if you were to go to the other institutions, are probably going to be the drugs of choice there too. So why do we use Ativan? Why do you think that?
I've heard that Librium's harder on your liver.
It is harder on your liver, Librium is. What else?
Availability of price.
Yep, price. Ativan's pretty cheap. Some of the big things is it works fast. When you give it, it works fast, and it stays a long enough time to where you don't have to give it as frequently, but it doesn't stay in your system for a long time. Like diazepam, its half-life is 7 days. So that means it could be in your system a very, very long time. Now, some people may excrete that faster, some it may take longer, but at least Ativan is more consistent. It's going to be in the body a shorter period of time. So that way it's not building up in the system. Another thing is it has no active metabolite. The way I remembered it in pharmacy school is if they're elderly, if they have liver dysfunction, use lots. Lorazepam, oxazepam, tamazepam, because none of those have active metabolites, which means that if they do have liver issues, which they probably will, if they're an alcoholic, right? Or if they're elderly and you're like, well, I don't want to oversedate them or have it build up, we'll use those drugs, which again is why Ativan is the drug of choice. Plus, it's available INPO. So there's lots of options. Librium, again, it's more of the, not really comparing it to the Ativan, because Librium we really only use for fixed schedule because it does last longer in the system. It has a longer half-life. But we use Librium over diazepam or Valium because it's more consistent. We know what it's going to do in the body versus with diazepam. It could last a lot longer than we thought it was going to be, and then it just keeps building up, and eventually they become oversedated. I don't see midazolam or oxazepam very often. Oxazepam is only available as an oral, so it's not as great as Ativan would be. And then midazolam is just very easy to overdose someone on that one. It's very short acting too. So, but depending on where you go, will be the difference on which one. So for the most part, these two are the most common, and those are kind of the reasons. Ativan is also really nice because I tell you about GABA overall, but there's actually little subunits of GABA. There's A and there's B. A is the reason why people go through withdrawal. That's subunit A, and lorazepam focuses on A, which is really nice. The rest of them are kind of more between the two of them, but at least Ativan is the one. But it also works really well too. So what side effects do you guys monitor for? What do you look for?
Sedation.
Yep, sedation's a big one. Yeah, so for me, sedation's a big one. Respiratory depression, especially depending on what other drugs they're on. Like for instance, in our protocol, we are using gabapentin as well as a benzodiazepine together, which there is that potential risk, but at least it's a lot better than giving it with like an opioid or something. But something to keep in mind to look out for. Other thing is dizziness, the fall risk, which is always a big concern. And if they're older, it can really affect how they think and their cognition and make that significantly worse. Which is again why we don't really like the fixed dosing regimen. At least with symptom triggered, you can have some breaks in between getting Ativan, so maybe your brain can kind of clear up again before it really interferes with anything. Any questions about benzodiazepines, why we use them, why we chose Ativan and Librium? Does that all make sense?
Is that across the whole hospital, ER, ICU, everybody's doing the same thing?
Yeah, that protocol goes throughout the entire hospital, right, Dr. Rodriguez? That's what I thought, yeah. Yeah.
Because we do see a lot of phenobarb coming from the ER.
Yeah, which we'll talk about that a little bit and why that may be.
Okay.
And actually with the phenobarbital studies, they're more in ICU and ER patients than they are in like a psych unit or a neurological case too. They use this a lot too. So let's talk about gabapentin because that was added by Ann and Dr. Rodriguez to the protocol. So we're using benzos, and those were the first line of the guidelines. Gabapentin was second line. So why are we using gabapentin and why are we using both of them? It has a really promising future for alcohol use disorder. So it's actually been used in the past for actual abstinence. So not the withdrawal part, but the long-term resolution of alcohol use disorders. So it's considered second line in that case. There are some better drugs that we'll talk about, but we've been using it for that for a while. But there has been more studies that have been coming out over recent years, and there was a randomized controlled trial earlier in March that was released about using gabapentin for actual alcohol withdrawal. And the thought is although it's not better than benzodiazepines when it comes to those symptoms, what it does is it helps you reduce cravings for alcohol. It helps to improve mood, anxiety, helps them sleep a little bit better. And I think the most important part is it's been shown to decrease the amount of benzodiazepines someone is using. So we're doing symptom trigger, but that still means they could be getting a lot of benzos, right? So they could be getting Ativan almost around the clock. But when we added gabapentin, we've reduced that. So that's less side effects, less risk. So that's kind of why you see, okay, we do gabapentin 400 3 times a day. That's the typical dose that they use for alcohol withdrawal. You can go up on that dose if you need to, if it's not quite doing what it needs to. But typically we do that. And it is renally dose adjusted. It doesn't hurt the kidney. So don't be confused about that. It just has to use the kidneys to get out, so we may need to adjust the dose. But why it helps, we don't really know what gabapentin does. It does a lot of things. We use it for a lot of things. We use it for pain, we use it for seizures. Now we're using it for alcohol withdrawal. But we think it has something to do with that GABA glutamate system, which is why it works so well. Because again, it's helping us slow the car down and turn on the brakes. So what do we do if the benzodiazepines don't work? You're giving them Ativan around the clock. They're getting up to 16 milligrams per day, and you're like, we can't keep giving them these benzos. We're going to put them at risk. They're going to fall. They're going to be sedated. Like, this is going to be a problem. So what do we do? You have an idea? Hence, I told you there are 3 big drugs: benzos, gabapentin, phenobarb. So this is really where phenobarb is going to come into play. So this is recent that the studies have really been emphasizing on this, and the new guidelines that should be coming out later this year, I don't know exactly when, from the APA, they recommend it more for benzodiazepine refractory, because barbiturates and benzos are very similar. We made benzodiazepines and we like benzodiazepines because they're the safer version of barbiturates, right? So they work very similarly. They still work on that GABA. They still work on the glutamate. But the big problem with them is really the side effects associated with them. That respiratory depression is real, especially if you combine it with the benzodiazepines, which I would not recommend. That headache, you have to really monitor drug levels for that one because it's a pretty narrow therapeutic window from 10 to 40. So it's a lot more dangerous to use it, which is why a lot of places aren't using it right off the bat. It works well when you use it. They did it in both benzo refractory cases, which they use about 14 to 16 milligrams per day as their cutoff of when they switch them over. Or there's also been some studies in the ICU, when it's severe enough for the ICU, to use it as monotherapy. So in our particular unit, it's probably not going to be used as frequently, just because it's more dangerous. Usually you need more monitoring involved with it, closer monitoring, but it is an option, and it's very similar, as you can see, to lorazepam. It also interacts with a lot of drugs too, which makes it really hard to use, which is why we also like benzodiazepines better, because they don't have that same interaction. So then we have more of the supportive care that goes with it. So we've got fluids, we've got vitamins, which you're probably very familiar with, and then we could use some antipsychotics or oncomedic drugs. So starting with fluids, as you know, people that are going through withdrawal, if they've been drinking for a long period of time, they're probably pretty dehydrated. So in our case, we don't give a lot of fluids on the psych unit, obviously, but if the dehydration was severe enough and their electrolytes are all out of balance, or potassium or magnesium, that puts them at risk of arrhythmia, so we may need to give them some fluid. So D5 half normal is the most commonly used fluid for that. but we may not do that very often, but it could be something that we would need to do. So vitamins, I'm sure you're much more familiar with. So why do we use vitamins? What's so important about vitamin B1, folic acid, a multivitamin? Why would we have to give that to someone who's an alcoholic?
They depleted their system from
Yeah.
drinking and drinking.
Yeah, because alcohol, it messes with everywhere in your body, including your GI system. So that means that those vitamins that you're supposed to be getting every day from your food are not getting absorbed. So what we do is replace them. Because if we don't replace them, if they're depleted, specifically with the thiamine, it can cause really lasting, sometimes irreversible effects that we could treat, but they may not ever get better. Folic acid, a lot of the time, is for the anemia part of it, but thiamine is the one that's really, really important. And this is the reason why. Have any of you, I think we had a patient on, older adults who had Korsakoff psychosis for a while there. But how often do you see this?
Every so often.
Never. It's pretty rare, thankfully, because we have this protocol that we're really helping on this. But if someone never comes in and they're not taking vitamins, this could be a really, really big thing. So Wernicke's encephalopathy is due to not having enough thiamine. So what thiamine is for is it helps metabolize glucose into energy in your brain. But when you don't have thiamine, kind of like with the metabolism of alcohol, instead of making water, which makes it safe, you don't have thiamine, that glucose metabolism becomes toxic. So it can just completely destroy your blood-brain barrier, and once you poke a hole in that wall, there's no fixing it. So that's why they get a lot of confusion. They have problems with their eyes. You may see some nystagmus and confusion. So those are like the triads. So when you're treating these patients, you're talking to them, really look out for these triads. We're trying to prevent them. We're giving them a multivitamin. We're giving them folic acid. We're giving them thiamine to help prevent this. But still look out for those, because if we don't touch it early enough, it can be irreversible. So the Wernicke's is more of the, I think, the neurological part of it. It's more of the confusion, and like the problems with the eyes, versus Korsakoff is more of the psychosis and amnesia that kind of comes with it. So kind of like having dementia. There was a patient when I was during my residency who had that we would go see him, we would talk to him, we would tell him our names, and then we would come back maybe not even 15 minutes later and it's gone. He didn't know who we were, like meeting us for the very first time. So it could be pretty severe. But this is why it's really important that we're giving the thiamine and that they're taking the thiamine. Most studies say, like, if you give 5 days, that should be good. That'll replete you. You'll be fine. But if they are going to continue to drink at home, maybe they should be sent home on it, because you're not getting rid of the problem. It's just going to keep reoccurring. So thoughts or things to think about when you're talking to the patient and deciding what would be the best. Here are the antipsychotics and then the autonomic drug that's on our protocol. So we use clonidine and then haloperidol if we need it. These are really used for the antipsychotics for the hallucinations and delusion that can occur, which a lot of the times those don't last for very long. They'll kind of go away as the alcohol gets out of the system, hopefully, if that's the case. Haldol's probably the most commonly used. You only give it on a PRN basis. It's not something that you automatically start, only if they really need it. But keep in mind that a lot of the antipsychotics do lower the seizure threshold, and they're already at risk for seizures. So watch out for that. We don't want to be giving them too many antipsychotics. And then the autonomic drugs are really just to help with the symptoms. They're not fixing the problem. They're really just masking it to where they're more comfortable until the alcohol gets out of their system. So we're lowering their blood pressure. We're lowering their heart rate, maybe making them less anxious. But if we are using a lot of clonidine and we just stop it, they're going to get rebound symptoms. So watch out for that. For the actual seizures, guess what the drug of choice is? Benzo. Yeah. So, I mean, what's nice about that is we're already treating them with the drug that is going to fix their symptoms anyway. Really what we'll do is either increase the dose, or maybe if we are using Librium taper, slow down. Because if they have a risk of seizures, they're probably on the fixed anyway. They're not doing the CIWA, they're just getting a little, just slow down that. It's another area where phenobarb kind of comes in handy too. It's good for benzo-refractory seizures if we need it. And then carbamazepine, if you have an IV, because I think oral carbamazepine is going to be pretty useless to you guys if they're in the middle of a seizure. But the IV is not available very, very frequently. So that's why benzo-phenobarb. Depakote and Keppra are not very well studied, but it potentially help if they're even more refractory. So, but for the most part, these seizures are pretty short in duration. It's not something that you're going to have to put them on chronic seizure meds for life. It's really just that short period of time, just until that alcohol gets out of their system. But the more you drink, the higher your risk. So again, kind of teaching them that too, like you're having these symptoms and these are bad, but it could be worse if you keep doing it or if you keep increasing the amount that you're drinking. One thing to notice, phenytoin does not work. So we do not use phenytoin. It's just not effective for withdrawal seizures. And then DTs. Everyone's spent a long time on DTs. The biggest risk factor is if they had DTs in the past, they'll probably have it again, so we're going to do fixed dose. So that's pretty much it. If they have history of seizures, history of DTs, automatically get Librium. But if we don't treat the DTs when they happen, which is really just giving them antipsychotics and making sure that the blood pressure doesn't get too high, there's a 20% mortality rate. So this is pretty high. So we really need to look after this, make sure we're treating it as soon as it happens. They usually die of things like pneumonia or liver failure or cardiovascular collapse. It's not actually the confusion that's getting them, it's their body being too active. So remember, he told you about this drug that makes him sick, makes him not want to drink. Do you know what that's the name of that drug is? Yes, so these are first-line agents for chronic. I guess before I go into this, is all of the treatment, the benzos, the gabapentin, does all that make sense? But these are our first-line agents, or the ones that I'm really going to focus on, because we already have someone on gabapentin. Gabapentin is considered a second line in this case. We already have it on it. So these are our first-line agents. Antabuse is really great if they're motivated enough. Because if they drink even a little bit, and there's been some cases on this email listserv that I'm on for other psych pharmacists who they were using topicals and they got really, really sick. So this is including mouthwash, like anything with alcohol in it. And then the big antibiotic is metronidazole can also cause this, but it'll make them very, very sick. And the reason why it is because it increases that metabolite in the alcohol metabolite chain that makes you sick. That's what it does. That's the purpose. So if you drink and you get sick, you don't want to drink anymore, right? But if someone wants to drink, they'll just stop taking it. It can last in their system for about 2 weeks, so they shouldn't just stop it and then go on a binge that night because they're going to get real sick. Someone has to be very, very motivated to use this. I've actually had a few patients ask me for it and say, this is the only way that I won't drink anymore. Fortunately, it's on bathroom. It's drug shortage right now, so not an option right now. So if you notice like we're prescribing it less or people are using it less, that's why, because it's just gone. But naltrexone and acamprosate are going to be our other big two. Naltrexone is used more often just because it's once a day, and people tend to tolerate it a lot better. They might get some nausea, but they tolerate it pretty well. But this is what I was talking about earlier, is we have GABA and we have glutamate. So we have these endogenous opioids that also cause this reoccurring cycle, right? Mm-hmm. That's where naltrexone works. It blocks the opioid pathway so that when you drink, it doesn't feel good. So you don't get cravings for it. So that's why this one is first line and works really, really well for alcohol use disorder because it targets that particular symptom. But it's really helpful for people to become abstinent. So if they're currently drinking and they want to become abstinent, this is really the drug for them. Versus acamprosate has been shown to be better than naltrexone at keeping people abstinent. So they're a little bit different. One helps you become, one helps you stay. The problem with acamprosate is it's 3 times a day. and I don't want to take anything 3 times a day. And it's not even something that you're like, oh, just combine the dough into one. Like, you can't. Like, the GI problems with it, it's just not tolerable, which is why it has to be 3 times a day. It can't be used in renal failure, is the other thing. Versus naltrexone can, but not in liver failure. So they're kind of like opposites of each other. And in your handout, I provided when to choose each agent. So when is it okay? When should it be cautioned, and when should it be avoided? So as you can see, like for a camprosate, renal failure is the only time you have to absolutely avoid it. For disulfiram, avoid it if they don't have that motivation or if they have a drug interaction. And then naltrexone, if they're using an opioid, because you will put them in withdrawal. If you give someone naltrexone and they're using like methadone for pain, or they're using heroin, and they didn't tell you, it's going to make them go into opioid withdrawal. So not only are they going to be an alcohol withdrawal, they're also going to be an opioid withdrawal. And both of them aren't fun. One's deadly, the other one's miserable. I mean, they're both miserable, but you have to at least give it 7 days. So when you're talking to patients and trying to get their story about what substances they're using, make sure to tell them that. Like, we might start you on this. So it's absolutely imperative that we know, have you used any opioids within the last 7 days? We don't want to put you in withdrawal. But that's it. Any questions, any thoughts? Yeah.
Pregnant patients, is there anything we need to know about that?
What do you mean?
Pregnant patients?
Oh, pregnancy. Benzodiazepines you can use in pregnancy. They're not. A lot of the times, especially with a lot of these drugs, it's risk versus benefit. Because is the risk of going through alcohol withdrawal, like, is it worse than the risk of benzos? And it is, for the most part. So yeah, you can use those. I can't remember if I have pregnancy on this list. I might not. But yeah, for the most part, all of these should be okay. But if you ever have any questions about pregnancy, I do have a chart that I can look through. Like, if you're like, hey, this person's pregnant, can you tell me if this drug is okay? Call me, let me know, and I'll look it up for you. Just be sure. Anything else? Any other thoughts? Hopefully this is helpful.
It was excellent. Yeah,
Sweet.
very
Okay,
good.
cool. I hope you enjoyed my meeting.
Yeah, great. I like that.
So if y'all can please turn in your evaluations, before I give you your TU.